So endocrinology is one of the more frequent chief complaints that you end up seeing in the field, primarily just due to diabetes. So that's kind of going to be more the focus of this lecture. Endocrine means it's a system that there's a system of ductless glands, right? So there is an organ somewhere in the body that is producing hormones, and that it's being secreted directly into the bloodstream. That's in contrast with an exocrine system, where there is actually ducts that move the hormones from one organ to the other. So, for example, the gallbladder, where it produces or it stores bile and then transmits it into the intestinal tract, that is an exocrine, part of the exocrine system. Whereas the pancreas, where it produces insulin, then secretes it into the bloodstream, is endocrine. Pancreas is both exocrine and endocrine because the pancreas is what creates bile salts. So just keep that in mind. Abnormalities in the level of hormones is usually what results in endocrine disorders, right? So there's too much or too little. There's two types of hormones. You have your steroid hormones, which are synthesized from cholesterol, and your non-steroid hormones, which are synthesized from amino acids, which are the building blocks of proteins. So your steroid hormones, primarily your cortisols, your sex hormones like estrogen, testosterone, progesterone, and aldosterone, actually have very similar chemical makeups, which is kind of cool in like a bigger picture kind of thing, because, for example, if you have a woman who's going into early labor, the problem is that oxytocin and ADH look very, very similar. So the body thinks that when she's dehydrated and there's ADH, antidiuretic hormone, floating around in her system, it starts to think that it's actually oxytocin and will cause uterine contractions, which is just kind of crazy because you can actually slow down or potentially reverse early term labor by rehydrating the patient. Structurally as well, cortisol can look a lot like estrogens, and that's sort of what happens in metabolic syndrome or PCOS, where the body starts making too much estrogen. In PCOS particularly, the body starts making too much estrogen, but the body starts to mistake it for cortisol, so it starts to raise the blood pressure, and it starts to have this stress response that's kind of inappropriate because the hormones start to kind of look like each other. Just kind of an interesting tidbit of information to have. On the other side, you have your non-steroid hormones, right? So insulin and parathyroid hormones, they control your blood sugar and your blood calcium, respectively. So there are different hormone receptors on different organs, okay? For the most part, each hormone can be relatively specific based on the tissue that the receptor is found. But if it also has the potential to have a general effect on the entire body. For example, cortisol, right? Cortisol is the stress response, so it can act on any organ or tissue in the body and create and produce its effects. Whereas, insulin works specifically on the cell receptors to move on all of the tissues to move sugar into the cells. So there's two different feedback systems that happen inside the body. You have the positive feedback system and the negative feedback system. The positive feedback system moves everything away from normal, right? So if you think of it sort of as oxytocin producing its desired effects during childbirth, where it's causing the uterus to contract until the baby is delivered, versus a negative feedback system when if you look at this diagram here, this is an example of a negative feedback system where your body will eat something which will cause the blood glucose to go up, which will cause the pancreatic islets of Langerhans to produce insulin. And then the insulin will cause the cells to increase the glucose intake until blood sugar goes down, right? And it goes back down to where it's expected, right? It's a negative impulse, and that stops the cycle, right? Because when the blood sugar hits a certain level, it's not going to continue to put sugar into the cells. And vice versa, right? So if you don't eat, your blood sugar goes down, your pancreatic islets of Langerhans produce glucagon and reduce the amount of insulin you have in order to increase glycogenesis from the liver, or glycolysis from the liver, and increase the blood glucose until it hits a predetermined point, right? And everybody's a little bit different. So you might have some people whose blood sugar is in the 80s when fasting. Some people might be in the 60s. And then you have type 2 diabetics where their fasting blood glucose could be in the 120s. Keep that in mind too, because if you do have a patient who has an elevated blood sugar, say for example in the 120s, and is a type 2 diabetic, and they're experiencing hypoglycemic symptoms, you might actually have to give them a little bit of oral glucose or something, because that is the new norm for their body, right? Just it's like their thermostat, their regular levels have been altered because of lifestyle and their underlying disease. So disorders of the endocrine system are either caused by an imbalance of the production or the body's ability to respond to the hormones being produced. And that's sort of where diabetes type 2 comes into play, right? We call it insulin resistance. The body either upregulates or downregulates the amount of insulin receptors on target tissues. If you have an excessive amount of blood sugar in your system, your body starts to downregulate how many insulin receptors that it has, because it can't store all of that sugar. So it starts to decrease, which is what happens with insulin resistance, right? Because now you might be producing insulin still, but there's fewer receptors that can work, which means that you need more and more insulin in order to lower the blood sugar, which doesn't really happen because your cells can only store so much sugar and can only be stimulated to a certain extent. Speaking of the pancreas, let us investigate. So diabetes is usually directly a dysfunction of the pancreas, which results in inappropriate fat, carbohydrate, and protein metabolism. Once the body is unable to use one component of digestion, it sort of starts to alter the ways that other metabolites are used. So your pancreas is broken down into three different cells, or three different endocrine cells. Collectively, they're called the islet of Langerhans, and those cells inside are the beta cells, the alpha cells, and the delta cells. The beta cells produce insulin, the alpha cells produce glucagon, and the delta cells produce somatotropin. Collectively, the beta cells and the alpha cells are what keep your blood sugar in check. So as I said earlier, so you have your beta cells, which will produce and secrete insulin. And then you have your alpha cells, which produce and secrete glucagon, right? So it's like the checks and balances for each other on that one dimension. And then you also have delta cells, which create somatostatin, which keeps growth hormone, the thyroid stimulating hormone, insulin, and glucagon in check, right? So it's another level of checks and balances inside the body to make sure that you're keeping that blood sugar in like a very narrow range. And things that, like cortisol, for example, increases the amount of growth hormone that is in your body, right? When you exercise, you put your body under stress. Your body secretes cortisol due to the stress, and that promotes growth hormone, right? So that's why when you exercise and you push your body in a good amount of stress, that you actually start to develop muscles, because you have that level of extra growth hormone. The delta cells of your pancreas keep that growth hormone from getting out of control, because not everybody can walk around looking like The Rock all the time. So insulin works as a key to a lock for cells. When insulin is secreted into the bloodstream, it connects to the insulin receptor on the cell. When it connects to that insulin receptor, it kind of opens up this other channel next door that allows glucose to flow into the cell. When the glucose starts to flow into the cell can use it for metabolism. In particular, the liver cells can start taking that glucose and turning it into glycogen to store for later, right? All of your cells store if they don't use the glucose right away, they store it as glycogen. When that insulin is connected to that insulin receptor, it brings that blood glucose down to a normal level. So you will have an influx of insulin immediately upon eating, right? There will be a period of time after you eat that your blood sugar will go up, will spike a little bit, and then as the insulin starts to work, it'll come back down. Insulin is the direct antagonist of glucagon and vice versa. So, if you do have a patient who has taken too much insulin, glucagon will counteract it. And you don't really hear of people overdosing on glucagon because it's kind of a more low-key hormone. But if that was ever to be the case, you would use insulin to counteract it. So glucagon does a number of different things in the body. So first of all, it promotes glycogenolysis, which is a stimulation of the liver to release its glycogen stores, right? So we just talked about how insulin takes that glucose and puts it into the liver and other body cells for storage. Glucagon promotes this breakdown back the other way, right? So glycogen is a large storage unit, okay? Whereas glucose is a very small transportable sugar, okay? So glucagon comes in, it tells the liver, hey, we need some sugar, break down some of those glycogens. It does, it breaks it down to smaller components so that it can raise the blood sugar and send that sugar out of storage and to the cells that need it. Glyconeogenesis is a secondary part of glucagon, which it stimulates glucose formation through the breakdown of fats and fatty acids. Okay, so in the event that you have a patient who does not have a high level of storage of glycogen, it will start to break down fats and fatty acids. Glucagon is a very slow-acting insulin, or a very slow-acting hormone, where it takes a little time. And it really is, to see a significant effect, you really do need a patient who has sufficient glycogen stores. So patients like alcoholics, anorexics, and bulimics, right? Malnourished people, they might not have sufficient glycogen stores to make glucagon work, okay? It also takes like 20 to 30 minutes for glucagon to make a significant impact on blood sugar. So if you are having a patient who's having like a hypoglycemic emergency and you can't get a line, the glucagon might be able to just wake them up enough to get them to eat something if you can't get an IV on them. Growth hormone is one of those hormones that is produced by the anterior pituitary gland, okay? If you guys remember from Princess Bride, Andre the Giant, commonly, one of the most commonly seen issues with the pituitary gland and growth hormone is a small tumor in that pituitary gland which causes too much growth hormone and creates giantism. Growth hormone, we talked about this already a little bit before, right? It promotes muscle growth, it promotes bone growth, it causes the liver to break down glycogen to be used in order to create new muscle and new bone. And overall, it tends to be triggered by stress. Okay, it could be good stress of exercise. It could be the bad stress of having a rough day. But this is, and that's part of the reason why if you're having a bad day, people who are under a lot of stress, and especially diabetics, if they're under a lot of stress, you'll see that they're having higher levels of blood sugar. Okay, same thing if you have a diabetic who is septic, right? That's a huge stressor on the body. The pituitary gland is going to release high levels of growth hormone and cortisol in order to try to help the body fight that infection. So you'll see higher levels of blood sugar in a patient who you suspect is septic. The problem with growth hormone is it doesn't really allow the muscles to absorb the glucose because it is a direct antagonist of insulin. So you have, all of these the higher levels of sugar, despite the body really trying to put it away, essentially. Normal glucose levels, blood glucose levels, are between 60 and 120. Usually they actually kind of lowered the 120 range. It should be 60 to 100. If the patient is fasting, their blood sugar should be under 100. Carbohydrates are like almost instant energy. I don't know if anyone has ever left a piece of bread kind of in your mouth and let it dissolve a little bit. They break down really fast. They go right into your bloodstream, and they allow the cells to kind of use them right away once the insulin is, letting that sugar get into the cell itself. If it is not immediately used, right, and the body cells, the muscles, and the liver have storage space, right? If there's a need for it, they'll store it as glycogen. If they're in a time of plenty, and they think that, hey, we're not going to have any periods of starvation anytime soon, they'll store that blood sugar, or that blood sugar as adipose tissue, right? So that's, when you overeat or you eat too much sweets, you start to get fat. So we talked about, I just mentioned this before, that you have, when you put the carbohydrates in your mouth, it starts to, kind of dissolve and you can taste the sugar. That's the first step of digestion, okay? You chew up food to kind of break down the cells so it's easier for yourself to digest. There's enzymes in your saliva that allow carbohydrates to be broken down, which is why they're so fast. And then when the food gets into your stomach, it starts to absorb some of the components. Primarily, your stomach is there to break down things rather than absorb. So that's why it's so acidic, right? It breaks all those things down. Once the chyme, right? That's the food that's moving throughout the digestive system. Once it gets to your stomach and starts to experience bile salts, that's where it starts to be called chyme. Once it gets into your intestinal tract, that's when it starts to actually do some more significant absorption, all right? So you get your amino acids and your glucoses, all of those things start to become absorbed through the small intestine, and then water, again, at the end is where the large intestine is where water is absorbed. The gallbladder is really essential for the breakdown of fats. So if you've ever put soap inside of a greasy pan and you see the little balls of fat that kind of come to the top, that's emulsification, right? It breaks it down into these little globules that your body can kind of handle a little bit better in terms of moving it along, digesting, and potentially absorbing it. So that's why your gallbladder is really helpful. That's what bile does. Bile also helps neutralize the acid that is coming from your stomach, because your entire intestinal tract is not an acidic, should not be an acidic location. As everything starts to become absorbed, right, your carbohydrates are transferred into becoming simple sugars in the bloodstream. Your fats become fatty acids and glycerol, and your proteins become amino acids. All of these things go directly through your liver. Okay, so all of the blood vessels that surround your intestines combine to go up through the body into the portal vein, into the liver, and everything else is broken down, right? It's your first storage step where your body's going, all right, we don't need this carbohydrate, we're going to store it as glycogen. Oh, lipoproteins, we'll make those over here. And it kind of starts to either decide what the body needs or doesn't need, what's going into storage and what's being passed on along down the line. If you don't use food, especially particularly carbohydrates, right after you eat them, right, if you're not exercising to some level or another, the glucose becomes stored inside of muscles as glycogen and can't be released back into circulation until the hormones are released to stimulate that, right? So until you have glucagon being excreted, then it can't be released back into circulation. Most of the time, it's just used by the muscle as energy. And this is what we talk about when, like, runners carb load. The idea is that a few days before a big event, if you eat a significant level of carbohydrate, you can restock those muscles with glycogen that have been depleted through the course of training, right? So you're going from that empty muscle here on the bottom to that full muscle up top, so that your muscle has more levels of glycogen to burn during an exercise event. Your brain cannot store glucose, but uses glucose as its only source of energy. Okay, so if you do not have sugar in your body, you will not be able to function as a human. Really kind of interesting evolutionary tidbit. Humans started to evolve larger brains once they figured out fire, because with fire they were able to cook vegetables and increase their levels of sugar and glucose intake. So that's actually where it's not that humans were able to cook meat on fire, it was actually that they were able to cook vegetables like potatoes and stuff, in which case the brain was able to use more sugar, and we were able to continue evolving into the creatures that we know and love today. I'm sure everyone's heard of the keto trend right now. Your body can metabolize fat as a energy source. However, it is not as efficient as carbohydrates. And when it does break down into ketone bodies. So ketone bodies are going to be important when we talk about DKA in a little bit. So kind of keep that in the back of your mind. So about a third of the glucose that goes through the liver is eventually turned into fatty acids. The fatty acids are required for various hormone production. Triglycerides do serve some purpose. Cholesterol in your body do serve some purpose. Cholesterol's really what your brain is primarily made out of, which is why they found that people who took statins can actually end up with memory loss, because the statins don't care what cholesterol they're breaking down. They just break it down, including your parts of your brain. So fat is an essential part of your diet, but too much, like anything else, is not a good thing. Protein, obviously, right? We have 3 macronutrients: carbohydrates, fat, and protein. Protein can also be broken down to create energy. Unfortunately, the number one storage unit of protein are your muscles. So people who are starving for an extended period of time, right? They're malnourished or whatever. They will look like wasting, right? And this was one of the primary indicators back in the day before we had a mass-produced insulin for diabetics. It was called wasting syndrome, because children would die from it, but they would just be wasting away because their body would start to eat away at their muscles to try to fuel their body. When protein is metabolized, it creates higher levels of urea, And urea in the can cause all sorts of high levels of urea can cause altered mental status, and also cause a lot of organ dysfunction, right? Because your organs are also made up of proteins. Glucagon. So we talked about this already a little bit, right? So glucagon tells the liver to break down the glycogen into glucose, and elevates the blood sugar in that function. The liver is like your buffer system, right? So your liver is really kind of one of the more important organs in your body. So as it gets rid of the glucose and starts storing it as glycogen, it can also do in the other direction. So, your liver does a good job of really maintaining blood glucose. Now, your liver can only do one thing at a time, right? So this is why they recommend that you don't drink alcohol with certain medications, because your liver can either break down detoxify the alcohol, or break down the medication so that it works. And if it does that, it's usually going to choose the detoxification aspect, because it doesn't want you as a human to die. So this is why you sometimes have people who have these wild derangements if there's a lot of things going on, because the liver gets overwhelmed. So we talked about the negative feedback control system, right? So if you have a higher level of glucose, the insulin goes up. If you have a low level of glucose, your glucagon goes up. And your body is very good at maintaining homeostasis, and it kind of stays within this very specific range so that you don't die. So when you have low sugar, the body stimulates the sympathetic nervous system to create and secrete epinephrine, right? And this is part of the reason that hypoglycemic patients are sweaty, tachycardic, right? They might be breathing a little fast, because they're the same symptoms as if you had administered them epinephrine, that fight or flight response, right? That fight or flight response in the longer term produces glycogenolysis, right? It causes the liver to break down glycogen into glucose, because if you're in fight or flight, your body is assuming that you're going to need that sugar in order to get away from an enemy, or make sure your muscles are functioning appropriately to run away. Growth hormone and cortisol also help regulate blood glucose, usually kind of on a bigger scale, longer term, rather than the immediate impact that you see with glucagon or insulin. And this is also sort of why you notice that patients who have elevated cortisol, right, will have higher levels of blood sugar, okay? It all kind of works together. So diabetes, your hallmark signs of diabetes is polyuria, polydipsia, and polyphagia, right? So increased urination, increased thirst, and increased hunger, because now your body, you might be eating, but your body can't get the sugar into cells, so the cells are still screaming out for energy, right? Now, you have this extra sugar floating around in the bloodstream, which is a very large molecule, starts to dehydrate you collectively as a person. And now as you're drinking more, right, your body's trying to get rid of not only the fluid, but the larger glucose molecules in the cells, or in the bloodstream, that they're trying to get rid of. Usually type 1 diabetes is due to a deficiency of insulin. The body is unable to make insulin. It's considered, quote unquote, it used to be called juvenile onset diabetes. For the most part, it does happen to be found in younger children. However, there is adult onset as well. They're starting to think that type 1 diabetes is due to an autoimmune disease. It also can be caused secondary to direct trauma to the pancreas, as opposed to type 2 diabetes, which is the vast majority, especially in America, of patients who have diabetes, um, it's caused by either a decrease of insulin production or an increased resistance to insulin. Okay, so traditionally these patients you'll see are obese, but they don't necessarily have to be obese. They could also be suffering from metabolic syndrome, which is usually caused by high levels of cortisol, promoting like a higher level of blood sugar, which then causes the body to downregulate the insulin receptors on on the various tissues in the body, and increasing the amount of sugar in the bloodstream. So metabolic syndrome is usually 3 or more of these. They're very closely related to derangements in hormones. So if you have a patient who is obese, who has high blood pressure, heart disease, high cholesterol, they are at increased risk of cancer. They're at an increased risk of type 2 diabetes. They're at an increased risk of non-alcoholic fatty liver disease, right? Dementia as well. Polycystic ovarian syndrome is like a premenopausal version of metabolic syndrome, right? So having polycystic ovarian syndrome causes higher levels of circulating estrogen and other sex hormones in the body, which then causes hypertension and heart disease and high cholesterol. Okay, so they're very closely intertwined, and trying to get control of it is very challenging for a lot of patients. Other types of diabetes, traditionally we really kind of see gestational diabetes in the emergency setting, where you might have a woman who all of a sudden is, has high levels of blood sugar because of, pregnancy. You will potentially see diabetes or deranged blood sugars secondary to infection. Rubella in particular tends to attack the pancreas, and which will cause, a secondary type 1 diabetes. And patients who are on long-term steroids, for example, I don't know, like asthma control, right? They can have a diabetes presentation because it's going to stimulate cortisol and therefore kind of affect the circulating blood sugar. Diabetes is kind of one of those diseases that has a lot of widespread effects. So beyond the decrease of glucose in the body cells, which means then therefore decreased glycogen, the circulating blood sugar is elevated. Okay, sugar is a very large molecule, which can do a lot of damage in the body, and particularly in the kidneys, which are very delicate and very sensitive to high levels of sugar, right? This is why you see diabetics and dialysis seem to go hand in hand, right? Because that if they are not good at controlling their blood sugar, they will end up pretty much blowing holes in their kidneys. If a secondary side effect of diabetes is that fats are not put in storage appropriately, right? So either if you have a patient who goes into DKA, their body will start to break down fats to try to create energy, which is not normal, a normal process, or the best process, I guess, is more accurate. Diabetics, because of that abnormal fat metabolism, have a higher risk of atherosclerosis, which then leads to coronary artery disease and other circulatory issues. And then when you have wasting, muscle wasting, because of that protein, right? That body is desperately trying to give itself energy, so it's doing that by breaking down fat, by breaking down protein, and using all of those backup channels as a way to kind of try to keep itself alive. So we kind of talked about this already, right? As the blood sugar goes up, the kidneys become responsible for getting rid of it. This can lead to severe dehydration, right? Because especially if the patient becomes altered at any time, they're unable to keep up with the amount of water that they need to keep their plasma levels high enough. also when you have, if you remember osmosis, or diffusion, I guess is more accurate, when you have these really large molecules of sugar in the bloodstream that can't get into cells, the cells try to dilute those really big molecules by putting more water into the plasma. Okay, so as those cells give up their own plasma, their own cellular plasma into the bloodstream, they become kind of like severely dehydrated. So you need to balance the blood sugar in order to rehydrate the blood cells, or not the blood cells, the cells in general. When the body can no longer move sugar into the cells, it switches over to fat metabolism. Okay? Fat metabolism does not produce the same level of energy as carbohydrate metabolism does. And one of the byproducts are ketone bodies, which are acidic. Okay? So as these fatty acids and these ketone bodies are released into the bloodstream as a byproduct of fat metabolism, the body's acid level starts to rise. Okay? First thing that your body does is try to compensate with the respiratory system. This is when you start seeing patients with a Kussmaul's breathing, right? Very deep, very fast. They're trying to blow off those acids to keep the body's pH in that livable range. As the acidosis starts to get worse, the potassium that's inside blood cells starts to leak out and into the bloodstream, following it up with nice hyperkalemia and leading to various cardiac dysrhythmias. Diabetes, uncontrolled or poorly controlled diabetes, is extremely deadly. Causes a lot of chronic issues. High levels of heart disease and stroke, neuropathies, kidney disease. It's not a fun experience. Managing blood sugar and diabetes, I guess, as a whole in the field really falls on the patient first and foremost, right? They need to understand what their regimen of blood sugar controlling medications is. So most of the time, they will be on a combination of insulins, usually a short-acting and a long-acting. The long-acting one is like an all-day to keep their blood sugar from spiking dramatically after they eat, where the short one follows it up around meal times. I had a patient once who gave herself she swapped her doses. So instead of giving herself a large amount of long-acting insulin and a small amount of short-acting insulin, she gave herself a large amount of short-acting insulin and a small amount of long-acting insulin. And she couldn't keep her blood sugar up because the short-acting insulin was doing such a good job of putting the sugar, the blood glucose, into storage. A lot of patients who are diabetics will have an insulin pump because it does a good job of keeping their blood sugar at a regular level. Because that's really the biggest problem, is these huge spikes and like the high spikes of sugar influx and these low drops of sugar because of like the medication administration. Instead, this insulin pump gives them like a general low level of insulin throughout the day, so it keeps it much more level. If you have a patient who is in a hypoglycemic state and they have an insulin pump on, you might really need to take it off or turn it off. No, don't take it off. Just turn it off. A lot of the times what happens with insulin pumps is patients can't afford the cartridges that go inside of them. So they don't necessarily have them on as prescribed, right? It might not be on all the time because their cartridges are expensive. This is really the biggest problem in American healthcare right now, is that people can't afford the things that are required to keep them healthy, like the cartridges for their insulin pumps or their insulin in general. A lot of other ones that we see really with the type 2 diabetics are the hypoglycemic agents. Most popularly it's used right now is glipizide and metformin. Metformin is also used off-label for a lot of other things, even just like weight loss in general. They are using that kind of off-label for various patients, especially those who have metabolic syndrome. It has the possibility of impacting kidney and liver function because that's how it kind of works. It stimulates the beta cells to produce a little bit more insulin. So if you have a type 1 diabetic who does not have functioning beta cells, these oral medications are not going to be helpful for them. I think everyone's probably managed at least one diabetic emergency so far in their career. These patients tend to be the first ones who want to RMA once you've woken them up because they know what happened. It's usually, oh, I took too much insulin and forgot to eat, or I've been a little sick lately and I didn't really alter my my insulin medication. Sometimes antibiotics and the oral hypoglycemic medications can cause increased dropping of the blood sugar. Patients who are trying to lose a little weight, who are diabetic, who then overdo their activity with not enough eating. And there's a number of other things that can cause hypoglycemia, including cancer, sepsis, etc. Usually with sepsis, I have noted that you really see hyperglycemia with sepsis. It depends on how, like, the patient's baseline health. And there's plenty of patients, I'm sure, who intentionally overdose on their own insulin. So for the most part, we're kind of familiar with this. You have patients who are shaky, sweaty, right? Those like signs and symptoms of epinephrine, right? They might have tachycardia. They might feel really anxious or nervous. They might have a bad headache or feel weak. Okay, these are all very traditional signs and symptoms of low blood sugar. On the other side, you have hyperglycemia, or the end results of hyperglycemia, which are diabetic ketoacidosis and hyperosmotic non-ketoacidosis hyperglycemia. First, diabetic ketoacidosis. So the body is either, you have a diabetic, traditionally it's almost always a type 1 diabetic, who is not taking their insulin, which then causes the glucose to become elevated, right? As the cells start becoming desperate for energy, they start using fat. So the ketones are produced. The acidosis starts becoming worse and worse, and then the potassium starts to leak out of the cells, right? So these are patients who you might see who couldn't afford their insulin, or have decided that they were going to try to cause themselves some sort of damage, or who are trying to stretch their insulin to last longer, who are sick. Okay, there's a lot of different reasons that patients can go into diabetic ketoacidosis. This is also one of the traditional presentations of young children who have yet to have been diagnosed with diabetes. They will present with diabetic ketoacidosis because their body isn't making insulin, and switches over to the fat metabolism. A lot of the signs and symptoms leading up to DKA are, the polydipsia, polyuria, polyphagia, right? Because the patient's, on a cellular level, the patient's starving and is becoming severely dehydrated. So as the acidosis and the starvation become worse, the body's trying to eat, the body is trying to dilute the blood sugar, right? Because high levels of blood sugar also make the blood very, very thick. The Kussmaul's breathing is a very common sign, as is confusion and that acetone breath, right? Some people say it smells like nail polish remover. Some people just say it's very odd smell. Kind of in the same vein as DKA is your hyperosmolar hyperglycemic non-ketotic syndrome, also called HONK, H-O-N-K, might be 2 N's. This is really what you see for the type 2 diabetics who are becoming hyperglycemic, okay? The body is still producing just enough insulin to prevent fat metabolism. So they're not getting that switch over to fat metabolism, which produces the acidosis and the hyperkalemia. However, I said this a little while ago, as the large blood sugar molecules start to accumulate in the bloodstream, it causes that shift of the cellular fluid, the intracellular fluid, out into the bloodstream. Okay, so the very high blood sugar, patient is extremely dehydrated, starts becoming extremely confused, will potentially present with the same kind of respirations and altered mental status as DKA, but won't have the hyperkalemia or the acetone smell that you would expect otherwise. It's a little, diagram. So DKA, right? Type 1 diabetics, hyperosmotic non-ketoacidosis. This is more type 2. Usually DKA seen in younger patients who are kind of irresponsible, a little more active, where HONC is your older type 2 diabetics. So there's a number of different ways that we can manage our diabetic patients. Whoops. So obviously, first and foremost, hypoglycemia, that is the faster life threat, okay, right? So hyperglycemia is a little bit of a slower onset, a slower management. They're not going to necessarily crash and die on you right away, as hypoglycemic patients are more wont to do. If you have a patient who is able to swallow, 100% give them oral glucose first, okay? If you don't feel like opening your oral glucose, you can also ask the family to make them a sandwich, right? So you want to have something that has a little bit of protein, a little bit of fat, and a little bit of and a lot of carbohydrates. Orange juice is great and all, but at the same time, that only lasts for a certain period of time. Okay, it's fast acting. The body's going to store that sugar right away. If you give the patient a more complete meal, they will manage to, they'll maintain their blood sugar longer than just with sugar. If you can't give that patient oral treatment, obviously you're going to give them an IV. If you can't get the IV, glucagon IMIN. Sometimes if you do have an IV and you have a patient who is not responding to D50, or we're moving to D10 now to be a little nicer in the management of diabetic patients, the glucagon can also be administered IV. One of the more important aspects of hyperglycemia is fluid replacement. We can do that. We do not administer insulin. We really don't need to worry too much about electrolyte, that we're giving electrolytes. We really want to just keep them on a cardiac monitor to make sure there's no sudden alteration in their cardiac rhythm, and you want to give them fluid, okay? You can give like 2 liters of fluid for a hyperglycemic patient, maybe even more. As you do this, you want to make sure that you also want to see if the patient has any sort of site of infection, okay? Toes, diabetics and toes, always check, okay? So not that we're going to manage this really that much in the field, because these are really chronic conditions that you're going to have patients who have them chronically and maybe need to manage them. But your thyroid is a very popular issue in the United States. A thyroid is a butterfly-shaped gland just in the anterior neck. It can be damaged very easily because it's not particularly well protected. It secretes 3 different hormones. Those hormones are T4, T3, and calcitonin. Calcitonin is more related with the parathyroid. Calcitonin is really what keeps your blood calcium level where it needs to be, and also helps put calcium into your bones. Your thyroid will release T3 and T4 when the anterior pituitary gland releases thyroid-stimulating hormone. For the most part, women have way more thyroid issues than men. Sure that someone's going to be researching that one day or another to kind of determine why that is. But undiagnosed thyroid problems cause all sorts of other issues, right? Your thyroid is what manages your metabolism, right? It keeps you from gaining too much weight. It keeps your hair intact. It keeps your bones intact. It keeps your heart healthy. So if there's some sort of disruption along that hormonal system, there'll be problems with that, right? For the most part, hypothyroidism is much more common than hyperthyroidism. It's a slow progression. If you're ever going to see a thyroid emergency in the field, it's going to be one of those people who hasn't seen a doctor in decades, okay? Most likely a woman. Hyperthyroid you don't see very commonly, but you may encounter a thyroid storm, which is rare, very, very rare, but is life-threatening. It's usually brought on by stress or some other infection, and it causes extreme tachycardia, hyperthermia, and all sorts of other dysrhythmias, possibly delirium. Graves' disease is the chronic version of hyperthyroidism. It causes exophthalmos, which is like that buggy eyes, and a goiter, which is that like big old bulge in the lower neck. So you have bulging eyes, which this is not exactly the best description of what the bulging eyes look like. But the goiter is the thyroid becoming enlarged in the neck itself. More commonly is you see hypothyroidism, okay? The medication Synthroid is synthetic T4. It's a super easy fix for it. You're literally just replacing the hormone, but it can take a little bit of time for the hormone levels to be adjusted appropriately. Patients who have hypothyroid, the number one cause of hypothyroidism is Hashimoto's disease, which is an autoimmune disease that attacks the thyroid. Undiagnosed hypothyroid or poorly managed hypothyroid can lead to what's called myxedema coma. Super rare, super, super rare. There's, it may not ever be seen in your career, but it basically causes this accumulation of like really thick mucus-like material in the skin. The skin becomes very thick. Hair starts falling out. The patient's extremely hypothermic. They'll be really have an altered level of consciousness. So this woman right here, undiagnosed hypothyroidism, okay? You can see her hairline's receding. She's extremely puffy looking. Her extremities are all like scaly and not looking that great. This is her a few weeks later after being treated appropriately with Synthroid. Same woman, right? Wild difference. But that's what can happen to you if you don't have your appropriate levels of thyroid hormone. Other rare diseases that you may not encounter in the field, there's Cushing's disease and Addison's. These are both brought to you by your adrenal glands doing either too much or not enough. Your medulla, right, the very inside of your adrenal glands are what produces epinephrine and norepinephrine, whereas the cortex is the outside part. It balances fluids and electrolytes, and that produces cortisone and aldosterone. Cushing is too much cortisol in the bloodstream, okay? Very commonly seen in women. Again, women just always end up with all the crappy problems, usually caused by an adrenal gland tumor or long-term steroid use, characterized by like a moon face, right? So if you ever had or ever known someone who had to take steroids for an extended period of time, they have what's called like a moon face, and it's just like their face is just puffed up. Patients who have Cushing syndrome also have a quote-unquote buffalo hump, which is exactly what you think it is, that like the skin on the very back of the neck starts to kind of get lumpy and protrude, increased body hair, diabetes, right, because we talked about that. Too much cortisol causes all sorts of other derangements in your blood sugar. So this is right here. This is what we're talking about, moon face, right? Your face gets all puffy and round shaped. You have excess facial hair. She's sporting quite a mustache here, and this purple striae. These are like purple stretch marks. On the other side, you have Addison's disease, which is not enough cortisol or aldosterone. Basically, anything that damages that outside part of the adrenal glands. Patients can live with Addison disease very easily by taking supplemental steroids. However, if there's any sort of level of stress that causes the body, it causes an imbalance between the level of, the level of stress and the amount of circulating steroids, they will have Addisonian crisis, which is a severe drop in their their fluid, which third spaces. It goes from the blood inside the blood vessels to out into the extracellular region and can cause significant shock. And the treatment for that is steroids. Traditionally, they use Solu-Cortef, but Solu-Medrol, which we carry on the ambulance, is also acceptable treatment. Again, very, very, very rare. You won't really see this in your career, and if you do, I want a love note about it. A lot of the symptoms that you see is patients who are very weak, very bronze skin. We talked about this already. Dehydration, muscle weakness, low blood volume. Moving on. That bronze skin we're talking about, something similar to JFK. He was thought to have Addison's disease, right? You don't look that tan all the time. Distribution of body hair changes, right? Body hair is very commonly tied to both your adrenal glands and the thyroid. And that's it. So really, the biggest concern that you really have in the endocrinology section should be the management of diabetes, both the high levels of sugar, DKA, and hyperosmotic, as well as the hypoglycemic. So keeping those two things in mind, you should be pretty solid.